Thank you. Okay, so I chose multiple topics to talk about today. The first one is how to maximize your time with a preceptor at clinicals and be successful. Discussing the expectations and goals with your preceptor at the beginning of your shift is important. Um, I know I was asked that question as a midwife student in the beginning, like what were my goals? And sometimes I was flustered and didn't really know what my goals were until more towards the end, where I was like, okay, I need to have this many births, I need to have more experience with this and that. So that was helpful. And my preceptors would be like, okay, let's try to find that for you today. And then we would eventually end up doing that. Some things you can't really control, like hemorrhages or shoulders, but you can discuss it with your preceptor, even if it doesn't happen, if you don't experience it with a patient that's going on. What else? And then communicate your goals like we talked about. So towards the end, you can start to take charge as the lead midwife, and you can choose how many patients you want to manage at once. Especially once you are in integration, you're closer to the finish line, so you have a lot more experience under your belt. So if you choose and your preceptor is comfortable with that, you can manage the entire floor. Or if you feel like you're drowning at a certain point, ask for help because that's what they're there for. And yes, let's see what else. And then debrief after deliveries, especially like I already mentioned, the postpartum hemorrhage and shoulder dystocia. So if you do have those during the deliveries, debrief after, or if you're anticipating one before, talk with your preceptor and tell them that I want to take the lead. Give me a minute to try to resolve it myself. If it doesn't, then please jump in, or I will ask you to jump in. Because I had one shoulder dystocia in clinicals, and my preceptor jumped in, and I never resolved it myself. So I felt really inadequate for resolving shoulder dystocias when I did become a actual CNM myself until I took another class, which I'll talk about more in a bit. So just having the open communication, and hopefully it's reciprocated by your preceptor. And let's see, my clinical site, for example, had a pelvis and a baby model. Not the big, it didn't even have a big one, it had a really tiny one. You can buy it on Amazon. I have it myself. So you can use it so you can kind of picture how the baby was coming out, what position, and then if you had the shoulder, how it was, how they resolved it, and that way you can run through the process together. And then when you have downtime, there's days where it's slow on the unit, so you can use that time to go over scenarios with your preceptor or practice suturing if they have kids, or if you have your own, whether it's your model, the fake skin model, or the, what is that called? The sponge, like a car wash sponge. I have that. Sometimes I use to practice suturing with. So you can use any of that. It's just to get your tactile skills, more hands-on practice. It's nothing like an actual bleeding perineum that you need to repair, but at least it gets the tactile muscle memory in there as far as how to use the utensils and the instruments. Okay. Next topic was tips for midwife interviews. We all know this, but dress professionally, be on time and a little early. What helped me was, even for my undergraduate, as getting my first nursing job, that school told me to create a career portfolio. And nursing interviews are usually a panel, so I would make like 5 is a good average to have, where it contains your cover page with an image and a name on it. You can either include a cover letter or just stick with your CV, and then you can get recommendation letters from your preceptors and also include your Typhon stats. There's a way where you can print out your all the types of visits you've done on Typhon. There's an extended way of doing it, and there's like a condensed version where you can print out and put in there. It makes it professional, and most of the time people don't do it. One of the interviews I had, they were really impressed by it, and they were like, oh, no one's given us this before. So it was good to have all the information on one page. And letters of a recommendation, ask your preceptors. Depends if you have one or two. If you have limited preceptors, then you can ask them closer to the end or give them a couple months heads up. If you have multiple preceptors that you don't anticipate seeing for a while, then ask them now and just start collecting it. That way you're not struggling towards the end when you're studying for boards and freaking out already. And then sell your experiences as a RN and a midwife student. So really hone in on what you've experienced, whether that's postpartum experience as a nurse or high risk labor, anything that you've experienced, or all the different places you might have worked as a nurse up until this point, or all the skills and experiences you've had as a midwife student, especially like the number of births you've had. Because for Cal State Fullerton, our requirement was 40 births, but they told us aim for 50 because that looks better as far as hiring. So I personally ended up with 58. And there were times during integration where I wanted to make sure I got those births. So I would go in if it was really busy for a couple hours, catch babies, and then go home. I wouldn't really count those hours because I needed the births rather than the numbers. So it just depends on your clinical site and how you can make that work for yourself. And then choosing different practice settings. So we all know that there's hospital midwives where you'll do inpatient, outpatient, and then you have your scope of practice, and then you have the MDs to consult with on the job. I currently work in Victorville at Desert Valley Hospital, so this kind of varies. I had my clinicals at California Hospital in downtown LA. So there was a midwife on staff, and then there was the OB attending on staff plus some residents. So there was a lot more support. My current hospital, I am the only in-house provider. The doctor is on call with me, but she's at home 10 minutes away. So there's that difference there as well, where you kind of pick and choose where you're most comfortable practicing, and how close you want the backup support to be. And this also ties into birth center midwives and home birth. So as the birth center, you're the only provider until the assistant arrives. And it's typically a group practice with a bunch of midwives, whether that's CNMs or LMs. And then they typically have a consulting physician that they can refer out to if anything's unusual. But that consulting physician is not on call with them. So if they ever need to transfer out for any reason, it could either be patient gets in their car and goes to the nearest hospital, which birth centers are typically really close in distance to hospitals. Like 5-10 minutes at most, or we would call an ambulance and EMS would show up and they would take the patient to the hospital themselves if it was a more emergent situation. And then same for home birth, the midwife would go to the patient's home, and then they would be the only ones there until they call in the assistant. And it's also key to network with other midwives in the areas, and also OBs as well. There are some handful of home birth physicians in LA that do attend home births, so people can call them in for non-emergent scenarios as long as like the relationship is built. Like a midwife who's never met this doctor, the doctor might not even show up because they don't know each other. It's has to be like a trusting relationship, and they've had to have met or worked together for them to feel comfortable. And also the patient has to be open to paying that physician or additional physician to come in, because their fee is completely separate than what they have been paying the midwife for their prenatal care and birth experience. Out of hospital care. So there are same things that can happen in the hospital that can happen out of hospital. But one main difference is that out of hospital care is for low risk patients. So they don't have diabetes, they don't have hypertension or preeclampsia. They might have a GDM A1, but if it's well controlled with diet and they don't anticipate macrosomia to a point where they think it's unsafe, then they'll be risked out of hospital birth and would be transferred to somewhere where they get to a hospital. But for those the low risk patients that end up delivering, we can still need to do neonatal resuscitation. So in labor at out of hospital births, there is no continuous fetal monitoring. It is only Dopplers. So we do intermittent auscultation. So we would, if in labor, if birth is not imminent and we hear D cells, we would call 911 and transfer to the nearest hospital. But if it's imminent to birth and the head's almost out and it's really close, then we will deliver the baby and then we will resuscitate as needed. So we do delayed cord clamping until after the resuscitation because we all know the cord blood contains oxygenated blood to the baby. So we need that oxygen to go. It's very different from the hospital in the sense that we don't cut and clamp quickly just to take the baby to the warmer in order to resuscitate there. An out of hospital birth, the resuscitation comes to the mom and the baby. And the next picture I'll show you. So it's the same equipment except the radiant warmers. So that we have the MMB bag for the baby, we have an oxygen tank. The daily suction is manual. So it's the same one that's used in the hospital. It's just there's no port to connect it to the wall suction. The midwife literally sucks on one side of the tube and the other tube goes into baby's mouth and then it sucks into it. It's a closed unit, so midwife doesn't have any of the fluids going into her mouth, but it just provides the suction that the daily needs. And then as far as a flat surface in order to resuscitate and like open the airway. Either sometimes towels are used depending on where the baby is at the time, or we can put a cutting board under the baby as a flat sheet or a sheet tray. That way we can open the airway and baby can be on a flat surface because most of the time they're either having a water birth or they're in the bed and the bed is like comfortable and soft and we want a flatter surface. If you are thinking of out of hospital birth, I highly recommend taking Karen Strange's NRP class because it is focused on NRP in the out of hospital birth setting. My NRP skills personally were honed in at the birth center because at the hospital you have NICU to rely on, you have RT to rely on, whereas out of hospital you are it with the midwife. So it's great experience in that sense to really know how to handle it yourself. Show you this picture. This is what a neonate NRP looks like in out of hospital birth. So they didn't even use a cutting board. They just positioned the baby on mom's chest. So the airway's open in between her breasts, kind of hanging back there. They have a stethoscope they're listening to. They have the MMB bag. They're giving PPV. Baby still looks connected under all those blankets. And yeah. If we do all the resuscitation and baby's still satting low, we have a pulse oximeter too. It's a handheld one. If baby's still satting low after we've done all the interventions, 911 would be called and baby would be transferred to the nearest NICU. But these are all rare cases, but they do still happen and it's a really good way to hone your skills. Especially as a midwife in a hospital, we don't have these hands-on skills because The nurses will take the baby and do NRP. So we just focus on moms. So this is different. It's like we're the whole package out of hospital. You're the mom, you're the baby, you're everything. And then another common complication that we can see is postpartum hemorrhage. So typically out of hospital birth, we don't have, patients don't have IVs because we're not intervening, they're laboring themselves. There's just no need. In case of an emergency, we do have IVs, so we do start the IV. But in the meantime, if the IV is not started or anything like that, we have IM drugs that we can give, like IM pit we can give if they're starting to hemorrhage. They have all the other uterotonics too, so they'll have methogen. They can have hemabate, cytotec, and TXA as well too. So all of these are still options out of hospital. It's just a matter of the order, kind of depends if you have the IV started or not, and you'll start with other things and you'll get the IV in and you can mix your own oxytocin with LR. And then we would monitor the vitals and call 911 if it's not stabilizing. And then, let's see. Cost and insurance typically for out of hospital birth, it costs on average 7,500 for the entire pregnancy. So prenatal care, delivery to postpartum, average about there. It's a little higher or lower depending on who your midwife is. Or now there are the home birth OB, so they charge a bit more. And then there's a new birth center that's a OB and a midwife collaborative team, so that's great. Additional fees that they might have is like if there's medication that's needed during the birth that wasn't accounted for, or some labs that aren't covered. Usually labs are covered with PPOs and Medi-Cal, but not HMOs and Kaisers for out of hospital birth. So there's additional fees like that that might come up. Most places do give a super bill so that they can submit to their PPO insurance, but depends on the insurance and how much they'll actually get reimbursed for it. And people with TRICARE insurance, there are certain authorized birth centers that TRICARE covers their entire care, which is awesome. Oh, back to this picture. It was actually, this was a shoulder dystocia and a neonatal resuscitation. If you guys want to listen to this story, it's a podcast called Birth Hour, and you can find the link on the bottom. Okay. Early career strategies for laying the foundation for a rewarding midwifery career. Ask questions if you're unsure and learning from fellow midwives and OBs. Asking questions is really important because as we know as nurses, there's so many things to learn. Now, as a new provider, there's going to be a lot of stuff that we're still learning as we go because we are new graduates. So don't feel bad for asking questions. Hopefully the people that you ask questions for are supportive and don't make you feel inferior. Because unfortunately that is still a culture in some places of healthcare, but don't let that stop you from asking questions, especially if it's going to keep your patient safe and your license safe. And then always look up stuff too. That's what I do. I chose a place where I'm the only on-call provider in-house. So I feel like I learn best when I'm left alone. So, and I will ask questions if I need it. And the OB I work with, she's like, call me if you have questions, call me in if you need me. So it's a very supportive environment. And I like that. And I know that personally, that's what I needed. And then communicate with the nursing staff, especially when new orders are placed. My job, for example, it's an older, they use Meditech. I used Meditech as a nurse as my first job, so kind of remember stuff from there, but it had been 6 years. So I asked them a lot of questions too, like especially when it's ordered, and there were times where my orders weren't going through on their end. So it's just a lot about coordinating with everybody, not just midwives and OBs. And like I talked about the shoulder dystocia, I highly recommend taking the Spinning Babies Resolving Shoulder Dystocia class, the hands-on one, because that class helped take away the fear of shoulder dystocia for me. I took it mid-April and I had a shoulder last week or the week before that, and I was not scared. I did the maneuvers, and it was great. Says no one ever doing a shoulder. So taking additional courses like that will help, especially when you feel like you're lacking, like I felt like I was. So it helped me know different maneuvers and different ways to help me take care of that shoulder dystocia without potentially breaking a clavicle or a humerus, depending on what type of shoulder dystocia it was. Um, so that is really good because their version of resolving shoulder dystocia is different than what we've learned in school, and it gives you different tools to um, kind of think outside the box and how to do it even for epiduralized patients, because the class was mainly focused on out of hospital birth as well. But with my two-sided brain of in-hospital, out-of-hospital experiences, I was like, how can I modify that for an epiduralized patient? Um, One of the main things that they taught us was doing runner's lunge to give the provider more space in the pelvis to work doing their maneuvers down there. So I was like, how can I imitate that? I'm like, okay, we're gonna go lay on that side. We're gonna imitate runner's lunge with an epidural with being lateral. So we did that, and it gave me a lot more space to resolve the shoulder dystocia by removing the posterior arm. So there's things like that that you can be like, how can I change this? What else can I do? Asking questions to yourself and kind of turning your head as you're thinking about it. You know how we're thinking baby's position? Similar to that. Um, okay. And then ways to become connected to midwifery work outside of clinicals. Um, Join ACNM, so then you'll be able to join CNMA. And there is free membership for BIPOC students with the code CA 2020. During my last year of midwifery school, I was the student representative for CNMA, along with one of my other classmates. And that helped me get connected with midwifery all over California, which is nice to know people up north, San Diego, kind of all around, because it's great for networking too, because you don't know where job will lead you or who you might know that might help you get the job. So it's great in that sense, because as we know, there's not all hospitals have midwifery services. So it's nice to know which hospitals do and potentially get a connection to a job in the future, whether it's in hospital or out of hospital. And then attending the ACNM annual conferences, so you can build national connections as well, like know people in different areas. Um, and attending the CNMA annual conference as well, so you have more California connections. And they are actually having a meeting that's taking place in Los Angeles on August 26th. So it's in person or virtual. So hopefully, if you guys are interested, you can attend that and meet more people in the area. And then you can also volunteer in CNMA committees. So there are a lot of different committees. I'm currently on the membership committee. I send out swag to new members. So if you sign up for ACNM and CNMA, you might be getting a little either tote bag or fanny pack from me. And then there's health policy. They have a bunch of different committees that you can choose what interests you and join them. you can check out their website. They have all the committees listed there. And then this is my information. So my phone number and email, if anybody has questions or wants to chat, you can reach out to me. I love to text, so that's my main option. And then call, I'll answer if I can, or email me and I'll get back to you. I think that's it. Yep.